Here's lesson 25 in the EMT course. This one's on psych and behavioral. This pretty much wraps up our look at altered mental status. We're going to spend a little bit of time online looking at it, mostly focused on agitated delirium and helping you recognize that, which is a little bit of a different animal. And then we'll spend some time in lab. And again, all these altered mental status things are kind of rolled into multiple lab sessions and mixed and matched to help you differentiate as well as come out ahead of the game. And the same stuff continues to be the sermon here. Manage CVO, be an EMT first, then be a detective, but manage CVO, then search for reversible causes. Very few of them have reversible causes in the field. Hypoglycemia would, potentially hypo or hyperthermia might, and an opiate or opioid toxidrome probably does. And so there's a few things you can do. But in this lesson, we're going to talk about, again, assessment and treatment of altered mental status, but this time with a focus on behavioral psych issues. And then we're going to talk about excited delirium, also called agitated delirium, because that's the big deal. That's the danger to you and a danger to your patient. And wrap up with a real quick talk on patient restraint. So again, altered mental status, many causes. They can have more than one cause. That's not uncommon. People tend to mix alcohol and drugs with other things, and psych behavioral is no different than that. Very common that it would be involved with other substances and other issues. Always protect yourself and always protect your patient. I think it's important that we stage and wait for law enforcement. I think it's important that we make sure that we have sufficient help, even if we're not going to wait for law enforcement. So staging on the unknown or the known violent patient is appropriate, but also realize that there are many medical issues that we can go fix. And so to simply say that you're going to stage and wait for any overdose or any psych call is not appropriate, because you're withholding some care from patients who are not a real threat to you. And you're doing it based on dispatch information. And even the best dispatch systems are going to give you partial information or partially correct information. It is very frequently the case that when you get there, it's not what you were told it was going to be. And yet you're having to make decisions on staging based on what we know is incomplete and frequently erroneous information. And that's not a slam at communications operators. Dispatchers are stuck with garbage in, garbage out. So if they are getting bad information given to them, inaccurate or incomplete or uncooperative callers, they're doing the best they can to give you what they give you. Just realize that it's not a perfect product and in many cases has big holes in it. So protect yourself, both by staging as well as by a careful approach, and positioning around the patient, and use contact and cover, and stay focused but still situationally aware. And then also protect your patient. Just because your patient's acting up doesn't make them your enemy. Do what you can to protect them. And then always manage CVO, because really that's about all we can do for many patients, particularly the psych and behavioral patient. There isn't a fix that we have in the field for these sorts of conditions and problems. So really we just need to protect them, protect ourselves, and one of the ways we protect them is by managing their CVO. Constantly, persistently assessing and managing their CVO. So what are we talking about here? Well, we're talking about some depressed patients. We're talking about some agitated, euphoric patients. We're talking about patients who may be temporarily altered and with a delirium versus chronically altered with a dementia. We're talking about patients who are hallucinating. They're seeing things that aren't there. And people who are paranoid in that someone's out to get them. So a general rule is to say, when the patient says, I see bugs or monsters, you do not say that you see bugs or monsters. You say that you believe them, that they are seeing bugs and monsters, but that you don't see them and they aren't really there. You believe the patient feels like someone's trying to kill him or harm him, but you don't believe that that's going to happen, and you're going to help protect the patient. So it's not okay to buy into their behaviors and their hallucinations and their feelings, but it is appropriate for you to say you believe them, that this is real to them, but help them to understand that it's not real, and they are safe with you, and you're going to protect them, and you're going to protect yourself, and then you do as much CVO as you safely can. If you're not able to safely measure a blood pressure, well, then maybe you can just estimate with palpating a radial pulse. In some extremely agitated patients, you may have to just go with the patient's talking and walking and moving around, so his blood pressure is not terribly low right now, but it wasn't safe enough for me to measure it. And so I guess the thing with these patients at the BLS level is don't try to solve it. Be there if there's a life threat, and don't make it worse. Don't lie to them and say that you see things that aren't really there. Be truthful with them, and just don't expect to be able to solve too much of a problem. But I really, we really need you to know about agitated delirium. It's also called excited delirium. I don't know if we're going to finally land on one or the other, but it's called both things. Here's the deal. These folks can be in a severe medical problem that appears to be psychiatric and behavioral. They're extremely strong. They don't get tired. They don't know they're exhausted. They don't know they're dehydrated. They don't know they're burning through glucose in a hurry. They're oblivious to pain, so standard restraint doesn't do much for them. Now, MACE works because MACE causes eyelids to spasm shut, but the pain from the MACE is also why MACE is helpful, because the patient, the person doesn't want to be in pain, and they can't see. Well, an agitated delirium patient doesn't feel the pain, and he still can't see, and it may just drive him even crazier. Tasers work because tasers, are a physiological situation, but as soon as the taser application stops, the patient goes right back to being out of control, and they don't feel the pain from the taser. The deterrent of a taser, either dry firing it or applying it once, is that the person that has it applied is like, I don't ever want that again. I don't want it in the first place, or I don't ever want that again once I've experienced it. These guys, that doesn't even register with them. And so a lot of the less lethal restraint and methods to get these folks under control are less effective in the presence of agitated delirium. And so most police officers have some training in this, and they understand the limitations of their use and their various tactics. And they know that these guys are extremely strong, and they know it's going to take multiple people to restrain them. And there's a couple of things that are particularly important here. One is, how do we identify these guys? Well, they are the call typically comes in for a person who's partially clothed because they are very warm and they're taking off their clothes. And so even in cold weather, they'll be running around naked or just in shorts or something. And so abnormal dress for the environment. When you touch them, they are extremely warm. They are hyperthermic, and they need to be cooled off as best you can. They're also breathing rapidly and deeply, and this may not be as obvious unless you specifically focus on it, because they're grunting and groaning, and they're making what's called keening, which are animal sounds, guttural sounds, and they're spitting and cussing and jumping around, and their conversations are just bizarre. The words don't fit together, and they are extremely, extremely agitated. And they are breathing rapidly and deeply, and that's important. So we had talked in a previous lesson about diabetic ketoacidosis, about the extremely hyperglycemic patient having a metabolic problem that he's trying to compensate for with a respiratory mechanism. In other words, he's breathing rapidly and deeply as a way to get his body chemistry back in line. And that's what's going on with these guys. These guys have a metabolic acidosis. And again, I don't need you to know that term, but some of you do. And so what's going on is with all this extreme muscle activity as a buildup of lactic acid, he's become metabolically acidotic, and he's trying to do a respiratory alkalosis to compensate for that. So in English, he's breathing rapidly and deeply in order to fix a problem with too much acid buildup in his bloodstream from all of his muscle use. And so we need him to keep hyperventilating. We don't want him to stop hyperventilating. We need to not impair his ventilation. So as part of restraining him, we've got to make sure that we don't do anything to slow his breathing or impede his ability to breathe off that acid that's in his bloodstream, more or less. On the ALS side, sedation methods and such, it's very important that they understand this, and they do. And so they will attempt to gain control with early sedation in concert with law enforcement and their use of less lethal and manual restraint. And this is a full-on fight. The other thing I wanted to point out is that a lot of these guys are fascinated by flashing lights and shiny things. And so they will come towards you. And so you think you've staged 2 blocks up the street, and you're going to wait for more help, and you're sitting there with the light bar on your response vehicle, and next thing you know, the guy's coming towards you. And so there's no hard and fast rule. I'm just giving you this information that they are fascinated by flashing lights and oblivious to pain. They don't get tired. They need to be breathing fast and deep. They're very warm. Some of them are crazy to start with. Some of them are on stimulants, on sympathomimetics, and if you want to think back to toxidromes, but not always. Some of them have been drinking, some are intoxicated, some are high on this or high on that, and it is a complicated situation that involves a lot of drama and a lot of physical risk. And so I think it is safe to say that you should not, by yourself, approach or engage with these types of patients. I don't think it's even safe with you and your partner. I think 5 or 6 people would be appropriate. And we'll talk about some restraint stuff in a minute. But, is the scene safe enough for me to enter? Well, and if it's just you and it's one of these guys, the answer is no. Because it will be extremely difficult for you, regardless of how big and strong or how trained in tactical methods you think you are. The best trained police officer by themselves or the best trained soldier by themselves is going to struggle to restrain and deal with these guys without the use of lethal force. So what about restraint? Well, we use restraint to protect the patient from hurting himself and from hurting others. When we restrain them, we want to do that with devices that don't turn into tourniquets accidentally. So we're not trying to restrict blood flow. We're trying to restrict movement. We're absolutely not trying to impair ventilation, so we do not restrain people face down and never hogtied. And so in the past, some of those things have been used, and you may hear stories or you may work with someone who has a great deal of experience, but they haven't improved their knowledge in the last few years, shall we say. A good plan is to have 1 person per extremity. We like a 5-person team. So somebody has the head and is giving commands, and 1 person for each arm and leg. And it's very pit crew-like in that if you're assigned to the right leg, then you take care of the right leg. You don't look at the left arm. You don't talk to anybody about the right arm. You work on that left leg. And if somebody gets kicked by the left leg, that's on you. It's your leg. And so that extremity, 1 per extremity thing works pretty well. Unfortunately, we don't travel in 5 packs, so we're going to have to wait for some more help. And then if law enforcement gets involved, and in many, if not most cases, they are involved, and they start using handcuffs, then cops stay with their cuffs. We don't. It's not a safe practice to have a restraint applied to a patient that you can't rapidly remove. And so if you need handcuffs to bring this patient under control, then the person that owns those handcuffs needs to stay with those handcuffs. Most ambulance services have a policy on restraint, and this would be an element of that policy or protocol that should be followed. From the ALS perspective, there is some chemical restraint that can be used. You start with verbal, then you move to mechanical, then you moved to chemical. When you're using chemical, you continue to use verbal and mechanical. But at the BLS level, we don't have chemical restraint options. And I'm speaking of something like a Versed or a Halidol or a ketamine is very fashionable these days. But that's not an option. You just may be present while that's going on. So what you should realize is this, that chemical restraint has to be administered, IM or IV, and the effect doesn't take effect immediately. Now maybe IV ketamine in a legit dose is going to work really, really fast, but still there's going to be a period of time while you're assisting, while ALS administers the sedation, and there's going to be a period of time while it soaks in, so to speak. And so these are difficult situations, and we'll talk about it and practice a little bit in lab. So in summary, if the patient's suicidal, why wouldn't they be homicidal? Everybody has a weapon until proven otherwise. The 95-year-old lady at the nursing home may have a weapon, and so the only real safe way is for you to be a little paranoid and do a physical exam and search for weapons. The best practice on restraints is restrain extremities without making tourniquets. One person per extremity is the ideal way. And then also don't impair ventilation in any case. Medical things can cause people to be behaving strangely, so as with any altered mental status, always rule out hypoxia, hypo or hyperthermia, hypoglycemia. Try to remain calm, try to be respectful, try to show some empathy. Don't lie to them, don't buy into their hallucinations, but treat them professionally and respectfully. And that's very difficult when you're fighting them. It's very difficult to fight off anger when you're feeling attacked. That's just natural and normal. But do your best to regain control should you feel yourself lose it for a minute, and do the very best you can. If you're being attacked, you should use time, distance, and shielding. You should limit your time around a dangerous person. You should maximize your distance. And if you need to do something to strike a patient or do something in order to get free from them, it's all good. It's all allowed. If you're feeling a threat to your safety, you're allowed to do whatever's necessary to get yourself free. And that's going to cause an adrenaline dump and a burst of anger in almost every case. What you're not allowed to do is then act on that anger and go back at them and pummel them or do something punitive to them. So you're allowed to disengage, but you should not re-engage. And then there's going to need to be restraint. Once I restrain somebody, they stay restrained. If you were acting up enough for me to need to tie your extremities down, they stayed tied down the whole time you're with me. I'm sorry, that's just the way it goes. And so this is difficult, but at the same time, it's not a complex concept. Do what you need to do to keep yourself and your patient safe. Don't do anything mean to them, to punish them. Try to be as respectful as you can and realize that it may not be that they're just mean and crazy. It may be a medical cause as well, and so let's always try to rule those things out. So that's the end of this one, and we'll see you in the lab.